Hi, I'm Andrew Einstein, a cardiologist at Columbia University Medical Center in New York, and it's my pleasure to welcome you to Molecular Imaging Highlights from the American Heart Association Scientific Sessions in Orlando, Florida. The American Heart Association Scientific Sessions is one of the world's leading cardiovascular meetings. There are about 25,000 people here to share the latest news and advancements in cardiovascular medicine. And we're talking about some of the latest advances in cardiology medicine, and in particular, focusing on molecular imaging and molecular medicine. Mouaz Al-Mallah, thank you very much for joining us today.
Thanks for having me.
You're welcome. So I'd like to begin by explaining some basic terminology. What do the terms coronary and myocardial refer to?
So we're talking about the heart here, and the heart has muscle, which is called the myocardium. And to get blood supply to this muscle, to the heart muscle, we need arteries to get blood from the aorta to the heart muscle. And these arteries are called coronary arteries. And there are two main arteries, one on the left side, which brings blood to the front and the side of the heart. And there is one on the right side, which brings blood to the lower portion, part of the heart muscle, or the myocardium. And it's very important to have good assessment of the coronaries because sometimes they could get involved in certain diseases like coronary artery disease, which is resulting in blockages in the arteries of the heart and limiting the amount of blood that reaches the heart muscle.
Why is it important to measure the blood flow in the coronary arteries and in the heart muscle?
So one of the early signs when a patient starts to develop a blockage in the arteries of the heart is that the myocardial blood flow, or the amount of blood that's reaching the heart muscle, start to come down. And this is one of the very early signs that happens even before there is a problem with the contraction or the pumping function of the heart. This also happens before there are any electrocardiographic changes, which is also called EKG changes, which is used by physicians to track whether there are changes in the heart function and if there's a scar in the heart. So it is very important to measure the blood flow to the heart muscle to get a good idea about how much blood is reaching the heart, because this might be a reduction in the amount of blood reaching the heart muscle. It could be one of the very early signs that is indicating that there is a problem in these arteries. By fixing this problem by medications, sometimes by other means, this would result in salvaging the heart muscle from getting further damage like scarring and other problems.
What current approaches do physicians have to measure blood flow in the coronary arteries and the heart muscle?
So there are multiple tools. Most of the tools that have been used before were like not measuring the blood flow directly, but rather measuring the impact of reduction in myocardial blood flow, or the amount of blood flow reaching the heart, on the function of the heart, like looking, for example, stress EKG. So when there is decrease in blood flow to the heart, then there are some electrocardiographic changes that
So you put the patient to exercise on a treadmill, and then you monitor their electrocardiogram and look for abnormalities there?
So that would be one tool to do it. There are also sometimes you can put somebody to exercise, or you give them a pharmacologic, or you stress their heart using medications, but then you can take pictures of the heart using ultrasound, or it's called stress echocardiography. It can be done with exercise, it can be done with dobutamine, or like with medications. And this also tells us if there's a problem in the blood flow to the heart, then we can see some problems in the contraction of the heart muscle, which is an early sign that there is a reduction in the amount of blood reaching the heart muscle. Another way, which is using some radioisotopes or some nuclear medications, which allows us to measure the blood flow either directly or indirectly. Indirectly using, for example, SPECT imaging, or what people call using gamma cameras, which allows us to gather some information about how much blood is reaching the heart, but more on a qualitative way rather than fully quantitative. If we want to measure it quantitatively and exactly how much milliliter is getting to each gram of the muscle of the heart, then we have to move to higher end technology. And this is right now available clinically using positron emission tomography, which is one way of nuclear imaging, where we inject a radioisotope both at rest and then we stress the patient, and then we inject the radioisotope at stress and gather more information about how much blood is reaching the heart at rest and how much blood is reaching the heart at stress.
With a traditional SPECT camera, not a more novel technology, is one able to quantify the amount of blood flow to the coronary?
Not as good as what you get with PET. There are some research, but it's not as robust, and it has not moved to the clinical practice yet.
So this is really a virtue of PET imaging.
Yes, and it is very easy to do it. In fact, all of our data is acquired in this mode called list mode, which we have to reconstruct it to get our regular images for study interpretation, but we can also reconstruct it in a dynamic mode to get the myocardial blood flow.
So the data is there already for taking the pictures of the heart. You just reconstruct that data in a different way, and you're able to determine the blood flow.
Exactly. So there is really no extra cost to the patient, no extra time required from the patient, no extra radiation exposure. It's purely computer processing and reconstruction.
Icing on your cake.
Exactly. So it comes at very limited cost to the patient.
You presented some novel data here at the American Heart Association scientific sessions about myocardial blood flow. What was your goal in conducting this research?
We have been trying to find out if this absolute myocardial blood flow quantification adds to what we know from nuclear imaging. We know that in nuclear imaging, if the heart function is low, that predicts future cardiac events like cardiac death or future myocardial infarction. We know that if there is significant perfusion defect or a significant amount of the heart not getting enough blood, then this will result in significant events in the future. These patients tend to have higher rate of cardiac death and myocardial infarction. So we're trying to see, does this extra information that we gather add to extra clinical information to tell us who's a high-risk patient or who's not a high-risk patient? And we found significant proportion of our studies were abnormal. So there were certain areas that the patient was not getting enough blood to that myocardium. When we look at the global amount of blood flow, and this is at peak, so in other words, when we give the vasodilator or the stress agent, when we stress the heart and we measure how much blood is getting to the myocardium, and then we divided that into 3 tertiles, we found out that those patients who have the least blood flow, irrespective of the pumping function of the heart, irrespective of the amount of the heart muscle that's not getting enough blood, the myocardial blood flow, or the amount, the absolute measure of blood flow to the heart, is really impacting on the outcome of these patients. So it adds incremental value. It adds on top what we know. So we can sometimes see just a tiny amount of the muscle not getting enough blood. But when we look at the absolute quantification of the myocardial blood flow, we find out that this patient has potentially reduced blood flow. And with this, we can upscale this patient to become a high-risk patient, although the amount of perfusion defect is not as big as would someone expect from a high-risk patient. So this is a new tool that helps us to gather extra clinical information and potentially target more aggressive therapies, both medications and others, into this high-risk population and try to improve on their risk stratification and management, and hopefully impact on their outcome.
What do you think the future of myocardial perfusion imaging is?
Having a blockage in the arteries of the heart doesn't always mean that there is a reduction in the blood flow, because the arteries of the heart are very dynamic. Sometimes you develop collaterals, sometimes you develop many other tools where the blood can bypass a certain blockage. So the point here is that what really matters is the amount of blood reaching the muscle, rather than just whether there's a blockage in this artery or not. So it looks like myocardial perfusion imaging is going to be a great tool to help us identify those patients who would potentially benefit from aggressive therapy, both on the medical side or on the intervention side. So I do feel that everyone is going back toward physiology, both in the cath lab and in the anatomical side, but also on the traditional physiologic side of stress testing and myocardial perfusion imaging.
It sounds like there's a bright future.
Yes, I fully agree.
Mouaz Al-Mallah, thank you very much for joining us today.
Thanks for having me.